the terminus radiosynovial thesis was first described and defined by Delbar 1968. What is it? On the one side, we have the radio, meaning we use radio-labeled colloids that will go to the synovia, the inflamed synovial membrane inside of the joint. And because of the radiation of these radionuclides, the restoration of the inflamed membrane is done just more easy RSO. It's much more easier for me too. So let me focus on pain relief by using this method. We can regress joint inflammation. We can preserve, because of the regression of joint inflammation, we can preserve the joint functioning. If you don't move your joint, you will have much more pain and a reduced movement the whole time. So improvement of joint mobility is one important aim. And of course, a lot of people, it's the same as on the situation in patients with multiple metastasis of the bone. We have a drug therapy with a lot of side effects. Especially think of the field of patients with rheumatism, a high drug therapy with high side effects. And to reduce these doses, we can use a local therapy by RSO. So we want to improve, again, quality of life in this patient. So I want to image what I want to explain. What is joint pain? Where the pain is produced? Where is the pain growing? We have here a scheme of a knee with a normal situation, a normal sized synovial membrane. Because of something problematic, for example, rheumatism, the synovial membrane is inflamed, become thicker and thicker. Inflammation process is become more expansive. And because of the inflammation, some interleukins and other drugs are sent to the cartilage. The cartilage will be destroyed just by tumor necrosis factor also, and tumor growth factor and interleukin 6. And we want to stop this progress because we want to save the cartilage. We want to save the joint function. This is our aim. So where we can see the indications for performing this radioactive method, it is a local therapy of synovitis. This is very very important to know. You can have painful joints in the case of rheumatism, of course, but also if there is a villonodular synovitis, a very benign tumor progress of the synovia, we can have activated arthrosis or osteoarthritis with a swollen synovia also, a painful synovia also. So this all are indications to perform an RSO. It has to be a synovitis as a base of the pain. So what we have to do is to be certain inside the joint, meaning we are injecting radioactivity. We have to be certain intra-articular, not like injection of steroids. You can deposit steroids beneath the joint and you will get the effect, but not in the case of radioactivity. You will produce defects of the skin. We have to perform this method under aseptic conditions. we are using local anesthesia, but in normal case, we are quicker than the effect of the local anesthesia is coming over the joint. We have to aspirate a joint effusion, especially in the case of knee joint, just to get a free joint. And after injection of contrast media, normalized, we are using fluoroscopy in the puncture technique just to see where we are and just to see where the needle is. And because of this, you are injecting contrast media, and so you are secure inside the joint, and then you can inject the radionuclide and also a drop of steroids. In the case of Schoen scheme of the knee I presented you before, I just want to show you the structure of this therapeutic regimen. At first, we have the inflamed synovia, thickening of the synovia is shown very well. You will inject the radionuclide. It will go to the synovia phagocytated by the synovial cells type 1. And because of radiation, the fibrosis of the synovial membrane is done. The inflammation process is reduced and the pain also. So this is important to know. The therapeutical principle are irradiation of hypertrophic synovial membrane and sclerosis and fibrosis of the synovial membrane is done. The inflammatory activity is reduced, pain is relieving. So what we are using, we have so many nice radionuclides we have not heard about in this workshop. So I have to tell about perhaps about yttrium 90. It's just used in the case of knee. And we have also rhenium 186 for the middle-sized joints, for example, shoulder, elbow, wrist, or subtalar joint. And of course, erbium 169 for the smaller joint, meaning the fingertips. And why we are differentiate between the three radionuclides? Because of the range in soft tissue. Yttrium is going up to 1.1 centimeter into the normal tissue. So we can use it just for the knee. Rhenium up to 3.7 millimeters. So for the middle-sized joints, and erbium just 1 millimeter into the tissue. So it is just for the small size joints usable. So requirements are joint pain, of course, joint effusion and or joint effusion. Joint effusion itself, in the case of knee disease, it is an indication itself. And of course, you have to compare before and after performing the RSO therapy, the effect. So this is proven by the bone scan and 2-phase or 3-phase bone scan, scintigraphy. And if you have a positive bone scan just in the early phase, you have documented the inflammatory process. So, so a bone scan should be done, and you can use all the other diagnostic methods we can have. Ultrasound, for example, to clarify a Baker cyst. Some years ago, this was a contraindication for performing RSO in the case of knee, but nowadays it is an adventure to use the RSO in case of Baker cyst, because with every therapeutic application of radionuclide in the knee, the Baker cyst becomes smaller and smaller. So it is a therapy also of the Baker cyst itself. Sometimes we are using X-ray or body imaging like MRI just to exclude fractures, but it's not often used in the case of RSO. Let me show you how you can differentiate the cases of fluoride arthritis. We need the inflammation process because we are irradiate the inflammation process, this method based on the inflammation process, and differentiate from secondary arthrosis where we have not so good effects by using RSO. This is a typical blood pulse scan and bone scan of a patient with rheumatism. Where we have the active arthritis, we want to make our therapy. Well, over there where we can find at first a high perfusion rate and a high osteoblastic activity. Also in the finger joints, as shown in this case, or the metacarpophalangeal joints, the wrist on the right, the wrist on the left, you can easily describe a high perfusion rate and a high osteoblastic activity. These joints get a high profit if they underwent RSO. And the secondary arthrosis are those joints where we just find a high osteoblastic activity, but no perfusion, high perfusion rate, no inflammatory activity is shown. In the case of, for example, this metacarpophalangeal joints of the third and the fifth finger. So it's very easy to separate the joints for this method. Also, we can use ultrasound. For example, in this case of a knee, a chronic synovitis of a knee, you can easily show the thickening of the synovial membrane, of course. But in this case, you can discuss with the surgeon who comes first. First, the surgeon to resect the huge amount of synovial membrane, or should we perform an RSO? This is your work to do, to discuss and to think about what's to do first. But if you see such willies, this is nothing for the radioactive therapy. There the surgeon has to resect the willies and the dragon as shown here on this picture. Of course, we can perform RSO in all the joints we have, meaning the hands, the shoulder, the temporal mandibular joints also, and we can use also the modern imaging, SPECT-CT and PET-CT. I will show you. So let us remember the anatomy of the finger joints. This is a very small one with a dorsal white capsule. Here you have, you should perform the puncture to come in this joint. It's very easy. It's very easy if you are experienced. You have to do it by yourself. You have to learn it. And then it's a real easy way to perform this puncture technique. Here is shown the puncture technique by using a syringe in the metacarpophalangeal joint. This is much more easier than the middle joints because these joints, the distal and the middle joints, are very, very small. And here you can see also the protection of the fingers of the therapeutic stuff, just to protect from the beta radiation, your fingers from the beta radiation. And sometimes we are using finger forceps because you have to imagine that we are performing this therapy in fluoroscopy technique, meaning the radiation beam is coming from top or from ground down under. And so just one hand is inside the radiation beam of the fluoroscopy. These are some nice pictures. You can see the contrast media is well inside the joint shown in this both small joints. Of course, you can perform also the puncture of the wrist very easily. In using this kind of technique, of application technique, it's very easy and you need just seconds to come in and to perform this therapy. And after injecting the contrast media, you can see a very nice distribution inside the whole wrist. You can also make some pictures using scintigraphy method, because rhenium and yttrium have a gamma component. And so you can perform, of course, some nice distribution images like this is shown here on the right side. The puncture of the knee is the easiest joint because it's very big. You will fall into the joint. It is very easy to establish and to learn this at first. After tracer application or contrast media application, you can see the contrast media inside the joint. We can perform also pictures like this. But if you are performing SPECT-CT, it's much better to understand the distribution. It's much easier for your colleagues you are working with to show them what is going on, what I have done, where's the tracer accumulation inside the joint. You can see a clear demarcation of the yttrium colloid inside of the joint. And if you are specialized, you can use also PET-CT, because yttrium has also positrons you can use for imaging, for example, for statistical and scientific ideas. You can perform this method also in the hip. There you have to need 20 centimeter syringes, but it's also with nearly no pain to come into this joint. And you are injecting contrast media, like in this case. You will get the scintigraphy of distribution. And if you are performing SPECT-CT, it's very easy to show that the tracer is inside the joint and will irradiate the whole synovial membrane. The new issues, we are performing also the RSO as a RTSO, radiotympanoxenoorthesis, so into the middle ear in case of chronic tympanic disease. You can also perform sacroiliac joints, but this is very hard. This is one of the hardest way to come into the joint. There you have to use a CT scanner and make it in the CT scanner. Temporomandibular joint I have told about, because you have to remember that 30% of patients with rheumatism got headache. Headache suffers from inflammation process of the temporomandibular joint. So why not performing over there? We have published there a way, very easy way to applicate this without fluoroscopy, without CT scanner. It's very easy to come inside. So, of course, as I told you before, the Baker cyst is an indication directly for using radioactive therapy, because you have to know the recurrence rate is very high. Ask your orthopedics or the surgeons, they will tell you. The resection is very easy to perform, but the recurrence rate of this kind of cyst is very high, and normally this patient will come back 1, 2, 3 years later, and they have the same problem. And so you can perform by using ultrasound, inject into the Baker cyst the radioactivity using rhenium, because you can see it, you can perform imaging, and you can see the Baker cyst distribution is very good. After 10 minutes, this is a whole body scan, like you know from performing the bone scan, just to see if it's inside this cyst and not in the body. And 24 hours later, you see a little bit distribution into the joint of knee, but the most is implemented in the synovial membrane of the Baker cyst. And the effect is wonderful in reducing the Baker cyst volume. Radiosynoverthesis is very easy to perform also. We have to perform this not sooner than 3 months after the first therapy, especially joints with large effusion in the case of knees. There you have to be much more intensively in performing this therapeutic regimen. Or you have a highly thickened synovia, as I have shown you before in the case of knee. If you have decided to perform RSO, there you have to use up to 3 therapies to reduce this thickening synovial membrane. Yes, after RSO, you have to perform just to check it, the therapeutic effect, to perform the bone scan. Before the therapy was implemented of this finger joint, and after performing RSO, this is impressive to see that the inflammation process is reduced or is eliminated, and this has to be checked for up to 6 months later. So, doesn't work. There's something. This machine is working here. Oh, no. Yeah, okay. So, and when we are talking about therapeutic effects, we have also to talk about complications. Can you? But I can tell you, there is nothing to tell. The rate of performing. Oh, yes, thank you. Yes, the rate of radionecrosis, infections, or thrombosis, because you are performing an injection technique, has an incident rate of 3.3 per 100,000. This is nothing. And we are performing this under sterile conditions, so the rate of infection is very low. So this is very interesting. And interesting is also, we have published a study about complications, and the cases of radionecrosis were performed by radiologists who not know what for a radionuclide you have to use in cases of joints. When you use yttrium, not in the case of knee, but in the case of subtalar joint, then you destroyed the skin nearly in the whole region of a subtalar joint. So you have to be careful, and you have to be looking after the the radioactive material you want to use. So the outcome is very good. The better in the group of rheumatism patients, up to 70% profits in reducing of inflammation process and of pain. So this is very important also to know that this was a study with a follow-up to 6 years after RSO. And this is very impressive to hear. Because of this impressive method, we have founded in Germany a network of excellence, 21, to standardize and this method and to define the quality criteria. Also, a certificate is planned, public relations, and of course, mediation of hospitalizations to learn this method very good and effectively. And we are also in the internet if you want to write on us some news, please call us or write us. So let me conclude. Radiosonography is effective and safe, widely without side effects, and we can perform multiple joints at the same time. But we have to remember, this is a local method. If the patient has rheumatism, we cannot perform a therapeutic regimen against rheumatism. But if they are under drugs, under medication, and 1 or 2 joints are still producing pain and inflammation, this is the way to act, to use RSO just to reduce the pain and inflammation process in this joint. RSO or surgical synovectomy has to be combined, can be combined, have to be discussed before planning the therapy, and can be applied to inoperable patients and increase quality of life. So radiosonography thesis now more than ever. Thank you very much.
Thank you very much, Professor Norbert Chet, for very comprehensive presentation. I think we will have some discussion and any question after the presentation. Okay, and now we move to the next presentation from Dr. Nguyễn Huỳnh Khánh An, the Oncology Hospital in Ho Chi Minh City. The topic the result of the treatment of painful metastatic bone disease at the Ho Chi Minh City Oncology Hospital. I would like to invite Dr. Nguyễn Huỳnh Khánh An to the podium. Như vậy chúng ta sẽ đến với một cái bài báo cáo của bác sĩ Nguyễn Huỳnh Khánh An với cái bài báo cáo tên là kết quả của điều trị giảm đau trong ung thư di căn ở Bệnh viện Ung bướu thành phố Hồ Chí Minh. Xin mời bác sĩ Khánh An.
Good afternoon. It's an honor for me to be standing here to present to you about the result of the treatment of the painful metastasis bone disease at Ho Chi Minh City Oncology Hospital. And I am the Dr. Nguyễn Huỳnh Khánh An, and I will represent our team to inform to you this result. Firstly, I want to tell about the burdens of the pain in cancer patients with bone metastasis. It occurs thirdly in malignancy, especially in the breast, prostate, and lung cancer, and its consequence, pain, bone fractures, spinal cord compression, hyperthermia, reduce the mobility, and of course, it increase the mortality. And approximately 86% of patients with bone metastasis experience the pain and it decrease the quality of life. And in our center, the reality of bone metastasis pain management got many obstacles and difficulty, with complex and multifactorial pain mechanism. It got a wide variety of people with pain type and intensity, and the indirect pain assessment and monitoring in clinical practice. And there's some social economic barrier that could affect the treatment adherence and continuity in the pain control. And the patient, family, and the healthcare provider will lack of the communication to achieve the optimal pain relief. And the current treatment modalities for bone metastasis pain include the anti-cancer treatment with local and system treatment. And in nuclear medicine, we can involve to help the patient got the pain relief. And we can use a systematic analgesic treatment with non-opioid, OPI, some adjuvant analgesics with corticosteroid, pregabalin, gabapentin, or some bone-targeted agent like bifosphonates or denosumab. And there are some study to experience to the new drug in this state. Yeah. And compared to on radionuclide useful for bone palliation, with the history from the 1840 decades with phosphorus 32, and after that but right now this radionuclide were not approved anymore because the hematology toxicity. And after that we have the strontium 89, and nowadays I want to present more about the samarium 153 linked with the EDTMB laser program, and it's a compared to other beta agent like strontium 98 or before 32 or germanium 168 has some advantage with short half-life, could lead to the less bone marrow suppression, and it have the gamma emission allow for imaging. And right now, the most recent and advanced agent were the radium 223 with an alpha emission, and that could achieve some survival benefit in addition to pain relief, especially for the prostate cancer. I will talk briefly about this samarium because the professor just present in the morning, and we can see that the samarium mechanic of action exactly were not fully understood, but many involved in the reduction of in the pain mediator like histamine, prostaglandin, interleukin, and the reaction into medical factor, just as a reduction in periosteal swelling. And I will briefly about this physical feature of the samarium, in which we got the beta emission and the gamma emission that could have for us both treatment and imaging. Samarium EDTMB, the indication in our center and just as in many international guidelines with pain relief in patients with osteoblastic or mixed metastasis that demonstrate uptake in diagnosis bone scan and regardless the primary malignancy. And the contraindication were absolutely, of course, the pregnancy and breastfeeding, and the poor status of the bone marrow function and the renal function. And one of the key points we have to know, we have to clarify that in the life expectancy, it should be preferably be beyond the treatment to have the pain relief. And we have to got some retreatment reparation for the patient. Firstly, we have to discontinue any myelosuppression chemotherapy 4 to 6 weeks prior to treatment, and withhold external beam radiation for 2 to 4 weeks prior to radioligand therapy, we have to provide the patient all information about the procedure to help the patient got the mission well and ensure adequate hydration before, during, and after treatment, and the fasting is not required. And the dose, as according to the international guideline, we such as EANM or SNMMI or IAER, we have to do the dose about 1 millicurie per kilogram, and we should use the intravenous blood supply or cannula. We inject intravenous slowly over 1 minute, and we have to check catheter patency before the infusion, and we have to use the three-way stopcock to plug the syringe contain the radiopharmaceutical within normal saline, and we should avoid the extravasation of the radiopharmaceutical. And at the clinical practice of Listerol, we have the pain relief efficacy of the Samidrum about 50 to 90%, and the complete pain relief with the rate about 12 to 38%, and the duration of response varying from 1 week to 4 months. And we have a study about the efficacy of the treatment of the Samidrum, in which we have 12 female with breast cancer and 18 male with prostate cancer with a dose of Samidrum about 1 millicurie per kilogram. And they assess the patient in 3 time point about the before the treatment, 4 weeks after treatment, and 8 weeks after treatment, and they conclude that the radiotherapy can be recommended to improve the quality of life for the patient got the osteoblastic or mixed Bayesian to improve the quality of life. But Samidrum provide pain relief about over 15% of patients improve the quality of life, but there is no convincing evidence for a survival benefit. Only radium 223 can do it. And one problem about the Samidrum combined with bisphosphonates, according to many international guidelines, these 2 types of therapy can safely combine with together, and the bisphosphonates do not decrease the uptake of the Samidrum, so they could combine together to get the efficacy. But Samidrum have 2 side effects too. They can take the patient in the myelosuppression status. Patient will got the suppression about at the nadir at 1 month after the treatment and recovery by 2 months, and no grade 4 toxicity or irreversible toxicity were observed, and not overmeeting up and weakness or constipation or anorexia or pain flare happen in 12 to 20%, and mostly often within 72 hours after injection, and pain relief can be obtained or increase the dose to help the patient got free of pain. And of course, the secondary cancer will not can be care about it because we have patient in the class 4, the last stage of the cancer. And the problem about the retreat with Samidrum, we saw that the patient can be retreated with Samidrum if blood count recovery. And in our hospital, we can retreat the patient at least 4 months, 3 months, at least 3 months if the pain collapse. And from 2016 until now, we had 8 patient got the retreatment. Yeah. So briefly about the Samirum EDT-NB, we have that the mechanic bind to the osteolytic lesion, delivering localized beta radiation for pain relief and efficacy about the pain relief in more than 50% of patients in one set within 1 week, lasting up to 4 months and no rule survival benefit. Safety, the transition, myelosuppression, and my nozzle weakness in pain flare. And the combination is served with combine with the bifosfonate and avoid overlap with chemotherapy or radiation therapy to reduce the toxicity. And retreatment possible after blood count recovery at least 3 months. And go to the main part of my presentation, I will present about the result of the pain relief of our center. We do it to evaluate the energetic efficacy of Samirum by clarify the response rate and duration of pain relief, and to compare pain score before and after treatment, and to assess the reduction of morphine dose following the treatment. And we want to assess the safety, the radiation safety of this treatment. And we want to assess the hematologic toxicity. Our inclusion criteria were quite clear. First, the patient got the bone metastasis of the osteoblastic or mixed style with the good status of the hemoglobin, renal function, and life expectancy. In our center, there are so many patients who want to do this, so we use the criteria about the life expectancy over 1 month, and the patient were atlas cooperative and able to self-assess pain using by a numeral scale, pain scale, and under physical guidance. And this is an algorithm about our study. First, we select the patient who meet the inclusion criteria. We do the baseline evaluation before the treatment, collect the data of the age, sex, primary cancer type, previous treatment, site of bone metastasis, type of bone metastasis, pain location, pain score, and morphine doses. After that, we do the therapy with the dose 1 millicurie per kilogram. And after that, we evaluate patient at 2 weeks and 8 weeks after treatment, and we repeat at least 3 months if the pain relapse. The patient has to answer about it and determine their cell pain in a numerical rating scale from 0 to 10, separate into none with 0, mild pain with 1 to 3, moderate pain from 4 to 6, and severe pain from 7 to 10. And the pain response, firstly, complete response to be defined at the pain score of 0 without increase in analgesic consumption. And 2, the partial response to be defined at the reduction of 2 score from the scale. Yeah. Because some problem. Yeah. And And we use the classification of hematological toxicity according to the NCI or CTC version 4.0. Yeah. And the study gets some results. First of all, there were 27 patients were enrolled in our study, in which there are 13 patients got the osteoblastic type and 14 patients got the mixed type. And the mean age were 55.18 years, and the male to female ratio were 1:3. And the largest proportion of cancer was breast cancer with over 50%, and other were lung cancer and prostate cancer. The size of bone metastasis would include the vertebral with 88%, pelvis and rib is the most side. After the treatment, we can show that the pain response, pain relief will happen in the 74%, include 33% got the complete response, and over 40% got the partial response. Only 26% were no percentage were no response, and the onset of pain relief averaged at the 11.5 days, and the duration of pain relief is about 15.8 weeks. And we can see that in the diagram, we can see that there were the change of the pain score of the patient cell determined after the treatment. There were the decrease. And and the dose of morphine were decreased very significantly. Before the treatment, the dose were about average about 101.4 milligram per day, and after the treatment is declined into the 46 milligram per day, and the dose of morphine will decrease by over 50% after the treatment, with the B value about under 1.001, and only 18% of patients got the no change or increase the dose of morphine, and that is really good for the patient. They can get rid of the dependence on the morphine. Yeah. About the toxicity, we have some myelodepression with the white blood cell and red blood cell platelets got the toxicity with grade 1, 2, and 3, no grade 4 toxicity, and most of them recovery at the IQWiC assessment. About the radiation safety, when we do the clinical practice, we usually got the dose of the radiation, and we got this data at distance of 0.3 meter with shielding. The dose rate about 3.5 millisievert per hour, and at the distance of 2 meters with the shielding, is about equivalent to the background level. And at the distance of the 2 meters without shielding, the dose rate is about at this distance with shielding, and at the distance about over 3 meters without shielding, the dose rate about 1 millisievert per hour. And we conclude that the radiation activity at the discharge about 3.5 millisievert per hour, and is safe for our patient. The study conclusion about the efficacy of the samarium, about the response rate about 74%, include 33% of complete response, with the duration of pain relief about 15.6 weeks, and the morphine dose decrease more than 50% in response group. And under 20% of patients had no change or increased the dose of analgesics. The 70 were no graft. So what happened? And the 70 with no graft for toxicity and mostly recovery, and the radiation dose at the discharge from the hospital was 3.5 millisieverts per hour. And we conclude that samarium 153 EDTMB is visible efficacy and a safe treatment to control the bone metastasis. Aiming to the enhance the quality of life in a large-stage cancer patient. We have a case example, 98-year-old lady diagnosed with the lung cancer. The pathologic result were adenoma carcinoma with EGFR negative, PD-L1 TPS was 70%, and metastasis in bone, liver, and adrenal. And she experienced a severe pain with scar eyes and decreased the mobility. She has to move on a wheelchair. And her dose of morphine were the 90 milligrams per day, and she has to take 3 times per day with the emergency dose. We can calculate that she got 135 milligrams of morphine per day, and she got a lot of pain. And prior treatment, she got the carboplatin-based chemotherapy from first line to second line, and she got the concurrent immunotherapy with pembrolizumab. And we have the imaging with the bone scan before the treatment with a lot of bone metastasis. And she will receive 58 millicurie of samarium EDTMB intravenous, and following the response after 4 weeks, she have no hematological toxicity. She got a decrease of pain. She self-determined the pain score about 4, and no flare phenomenon because we use the analgesic to cover her to have her got the pain freeze, and she no. And the dose of morphine by dropped to the 30 milligrams per day, and no need to use the emergency dose. And she got the enhancement of the quality of life. She increased the working distance, of course, with the half of equipment and the half of the relative, but she can move a little bit far from her bed. That's a good improvement for her, and she can do some basic things by herself, and I think it's good for her. Yeah, this is the end of my presentation. Thank you a lot for your attention. Thank you.
So now I have the honor to introduce the last speaker of the very interesting and complex workshop we have had today. The last speaker, Professor Chachi, is talking about the symmetry and radiation safety in theranostics. Of course, we have a lot of methods by using theranostic. We have discussed about gallium PSMA and lutetium PSMA. We have heard about gallium imaging dotatate and lutetium dotatate, but nobody in real life is looking at the dosimetry and what is have for an influence in our way of discussing and optimizing the therapy. And the radiation safety has to be in our view. And now we can hear something about, please tell us some interesting details.
Thank you very much. to Dr. Alexon and the organizers for this conference. Thank you for this invitation. I will try to do my best in this 30 minutes that I have. I will be, I'm sorry to say, I will be just talking about the precision and protection and the safety aspect of theranostics. I will not dwell too much into the dosimetry. Thank you very much, and sorry for that. This is the learning objectives of this talk that I'm going to provide a significant findings in practical radiation safety during lutetium-177 and, or for that matter, actinium-225, to present the comprehensive best practice guidelines, as well as to assist radiation safety professionals in the implementation of safe, practical, reproducible, and effective radionuclide therapy, even at small sites with limited or no experience in radionuclide therapies. I hope I can be heard. Can you see the slides, and can you hear me as well? Okay.
We hear you, yes.
All right. Correct. So, all right. So a very brief history of my hospital. My hospital is about 200 years old. It has its humble beginnings back in 1821, and currently we're the biggest hospital in Singapore. And the Newsweek of magazine has considered us as the top hospitals in the world for the last 7 years running. And with that, let me talk about the radiation monitoring in radionuclide therapy. Very quickly, the new therapeutic radiopharmaceuticals with alpha or beta radionuclides are coming on board, and the radioactivity involved is generally high, with the need to ensure radiation safety, as what the last two speakers had mentioned as well. So it's because of the large mean infused radioactivity with either alpha or beta, and sometimes going about 5,000 megabecquerel per patient is utilized, with possible contamination of staff as well as the environment as well. So the primary concern is the potential internalization of especially of alphas and betas via inhalation, ingestion, and wounds. And as what the earlier speaker had mentioned, some of these beta particle emitters also have a gamma emitter as well, and that is helpful in the detection of contamination. But some alphas like radium-226 and 223s do not have a gamma emitter, and hence the internalization will pose a bigger issue. The nuclear medicine staff, generally radiopharmacists, medical physicists, nuclear med technologists, as well as the nuclear med physicians, generally may receive a unnecessary or a high radiation exposure due to managing these patients who are being treated with these radionuclides. Now, literature review concerning safety, radiation safety aspects in the preparation and administration of new alphas and beta emitters was done, and there is an absence of internationally available, harmonized, and sustained radiation safety training. So nuclear med staff and other non-radiation hospital staff, such as inpatient ward nurses, do receive a potentially a high exposure as well. The overseeing of this training and supervision of the personnel in radiation safety aspects, such as decon techniques, in the event of a spill, was compared across the institutions. And in general, the factors that affect radiation safety would be in the radiopharmacy, while we order the radiopharmaceuticals, receipt and unpacking of the storage, dispensing, internal transport radioactive waste, and the safe administration that involves the patient identification, ensuring the patient is not pregnant, breastfeeding, and infusion as well. So when you look at the patient preparation, the radioactive patient and the constraints, the radionuclide therapy, dose transportations, all of that, every aspect of it has got some, we have to look at radiation safety specific to that instructions, as well as specific to that particular task that we're undertaking as well. So the discharge of patients, of course, varies from country to country because of the limits and instruction to nursing staff, visitors, instruction all that needs to be looked after. And last but not least, the emergency procedures when there is a death, unfortunate death of a radionuclide therapy patient, that would we need to have SOPs to handle how we can look after such a patient, and if there is a decontamination, if necessary, due to a spill. All radiopharmaceuticals are prepared following high standards, and they need to be protect both the environment of the product and the operator as well, due to the high activities that we are dealing with. And radiopharmaceuticals generally are manufactured in controlled, environmentally and radioactively controlled areas, and all manufacturing steps have to take place in self-contained facilities dedicated to a single radiopharmaceutical. Reason being, we do not want to contaminate one radiopharmaceutical with the other, especially if one of them is a diagnostic and the other a therapeutic radiopharmaceutical. The key principles is to have trained and qualified radiopharmacy staff, adhere to safety standards, and certainly written procedures to ensure a harmonized practice and maintenance of standards and minimal risk to staff, patient, general public, and of course, the area that we work in, the environment. We need to ensure meticulous handling and proper containment to prevent contamination and exposure as well. And this is just a typical clean rooms kind of facility where you have a ISO class 7 or grade C radiochemistry room with your hot cells or isolators. And there's on the top on the left, there will be a change room where you can access that to go in. So the pressure different requirements are a positive pressure for pharmaceutical laboratory, while in the case of radiation safety, one needs to have a negative pressure. So there has to be a compromise between these two, and to ensure that we can comply with both the pharmaceutical requirements as well as the radiation safety requirements. So the key principles in good radiopharmaceutical practice is the suitable equipment that we require. Either it's a basic biosafety cabinet, a shielded one with laminar flow, vertical laminar flow preferably, and a shielded fume cupboard if we are dealing with aerosol emitting nuclides such as iodine-131. And of course, separate air handling units for different radionuclides, once again, to prevent contamination. Suitable materials should be available. Lab supplies, PPE, shields, transport containers are necessary as well. Now, I just want to highlight the difference between a fume hood and a vertical laminar float. Fume hood is something on the right-hand side. You can see it's certainly useful for dealing with radioiodine compounds, whereas a vertical laminar flow cabinet, basically where you have the laminar flow coming from the top to bottom with a HEPA filter over here and the return air going back in this way. So there's a distinct difference between the two, and many times I've seen some centers where they interchange the use of these two. The radionuclide therapy with alphas and betas emitting radiopharmaceuticals, safety needs to be incorporated inside the quality control testing. One needs to use the proper lead shielding, increasing the distance, and of course, reduce the time for the quality control test staff. And the use of long-handled tools are extremely important to reduce the extremity doses, and the containment by means of a syringe or vial shield to reduce the extremity dose as well. And with that, I wish to also highlight the use of appropriate shielding, like the one on the left-hand side. The picture, basically, it's about 6 centimeters of lead. It's suitable for high-energy gamma emitters, like even the PET radiopharmaceuticals or iodine-131. And if you are dealing with if you want to determine the pH of radiopharmaceutical, the probe, for example, is looking into a beaker where you actually shield this part. So the quality control staff can receive a high exposure if we do not look after every details of the radiation safety at different aspects. Like in this case, when we're doing quality control, we want to make sure there's proper shielding as well during during the testing, even though the staff are dealing with low levels of radioactivity in comparison to the synthesis or the infusion. But these staff are day-to-day exposed to these high levels of exposure, and these are naked sources that we are dealing with. Without much shielding, they would incur unnecessary exposure. So one needs to look after that as well. While we handle radiopharmaceutical, we need to monitor for contamination aspect as well. So the usual wipe test needs to be performed, and we are dealing with infusion sets such as this. This is a syringe pump with an L shield behind it. The nurse would stand behind the L shield while this patient could be seated in front. Now, the important aspect is to look after and to look for contamination after the either the synthesis or the infusion has occurred. Now, the three general means of infusing radionuclide therapy, the gravity method, the basically infusion pump method, and lastly, the pump method with a syringe shield. We generally utilize the syringe pump or method C, where I will show you some photographs in which where you see this L shield, stainless steel L shield in front of a patient, and you can see the silhouette of the patient on the stainless steel outside, and the nurses are setting up the priming, and this generally would be for peptide therapy using lutetium-177. And this is a close-up view of the syringe pump that sits behind this L shield, and you can see this nurse managing the syringe pump, priming it, and ensuring that there is safety for her. She's standing behind this L shield with the lead glass as well. Of course, her fingers do receive a certain amount of radiation exposure while handling this 20 ml syringe and of radionuclide. And of course, in this case, if you see this picture number 6, you can see a semicircular lead sheet or lead semicircular block, which is sitting on top of the syringe shield to cut down the exposure to her extremities as well. And of course, we assess the patient before we discharging the patient home. Now, the two hazards while we deal with this radionuclide is basically we are dealing with powerful gammas that can accompany the betas or alpha decay. And of course, we need to shield the alphas and beta particles, but not so significant because the range of the alpha particles especially are short, and they can be looked after by thin sheets of lead. Like as you can see, this L shield is generally something that you would use in your technetium laboratory, but that can be modified by installing it on a trolley with wheels that we can actually move it around, and that forms an excellent way of cutting down the exposure to the nursing staff or clinical staff while we use a infusion pump to do the infusion. So the important consideration, there are two hazards while dealing with whether it's a therapeutic or diagnostic radiopharmaceuticals. The two hazards are radiation hazards are, one is contamination and the other is the radiation exposure from the nuclides. The contamination is a bigger hazard in comparison to the radiation exposure one would receive from handling these nuclides, and because of the fact that contamination can lead to internalization or accidental intake, especially of radionuclide therapy pharmaceuticals. And needle stick injuries are basically a very easy way of internalizing these pharmaceuticals. So one needs to make sure that there are minimum steps or minimum possibilities of a needle stick injury as well. So the usual PPE are necessary, electronic personal transmitters, besides the OSL or TLD worn by the staff. And generally, we don't recommend pregnant staff to work with these radionuclide therapy patients. And of course, needleless connectors would help to prevent needle stick injuries and to provide disposable cutleries to these patients so that they don't contaminate kitchenware and end up contaminating the kitchen items due to the cleaning of them. And of course, something that worked for COVID. Practice good housekeeping and clean work habits as well. So the usual PPE would be something that worked for COVID, would work certainly for ensuring the contamination control of radionuclide therapy during radionuclide therapy. Some of the standard cleanup limit the spread of contamination, limit access to the area where there's a contamination, notify the RSO, use protective clothing and disposable gloves, and quickly soak up any liquid with absorbent pad and wipe up the spill. And for example, one needs to know the nuclide that you're dealing with. For example, radium is not strongly absorbed by work surfaces or floors, and you need to use a complexing agent like this or EDTA solution that will allow the complete removal of radium-223, for an example. So not all of them are water soluble, and one needs to look after that aspect of it as well. And of course, to check the success by doing a wipe test or direct survey meters if it has a gamma emitter. Of course, continuing cleaning and checking if necessary is important, and use a plastic bag to hold contaminated items such as this. And in the case of contact with skin or eyes, the affected area should immediately be thoroughly rinsed in water. So they should have access to this sort of decontamination showers and eye washes close to the place where radionuclide therapy can take place. And as I would say, it really depends on your hospital and on your requirements. The use of a handheld pancake survey meter would be really economical as well as effective way of controlling a contamination aspect. And some countries require area monitors based on your regulations. But very importantly, one needs to have these regular items that you would use in a decontamination, and they should be kept within easy reach of every room where there's a use of radionuclides, be it a scanner room, procedure room, for that matter, even in your interventional radiology suite, if you do yttrium-90 based Zyrtec or microspheres infusion for HCCs. And you need to have a checklist to ensure that all the items are there. And when you really want to use them, you want to make sure that all of these items are there. And you can generally buy these in your regular pharmacies or material management. And this is nothing more than a liquid soap solution that helps to soak up the radionuclides. And of course, this is something unique. You can't really get that from your regular pharmacy. And the practice of whether the radionuclide therapy can be done on an outpatient basis varies country to country, but most of the newer radionuclide therapies are treated as outpatients, like in Singapore. Proper facilities with toilets and shielding and survey meters are necessary prior to your start of doing these radionuclide therapies. And this is just a sample of how a room looks like. And and often we can use shielding, but do take note that this shielding is not the type that you find in diagnostic radiology with about 0.25 millimeters of lead, but rather this would be about close to about 4 centimeters of lead. So something that would be useful for iodine or lutetium for that matter. And if you have a patient which has a catheter, it would be good to store the catheter in a lead-lined container. And once again, the thickness of these lead on all 6 sides is about 2 centimeters. And if you have linen or some contamination of clothing, you would need to use a shielded stainless steel cabinet, maybe even with a ducting, so that the foul smell does not stay within the inpatient wards, and hence also look after the radiation safety aspect of it as well before it can be sent off for the central supplies for washing. And if you need to transport radionuclides from your hot lab to the radionuclide therapy area, be it outpatient or inpatient, you may need to traverse long distances, and often a trolley such as this might be useful, but the only problem is that if you put in lead-lined trolleys, you would certainly increase the weight, and something like this would weigh about 200 to 300 kilograms because of the sheer amount of lead in there, and therefore you may need to leverage on a motorized DC motor to help you to move this trolley around. And the delivery of lutetium or actinium-based radionuclide therapy, let's look at some of the radiation safety as well as aseptic handling requirements. And here what we see, this is transport trolley brought where we use a usual regular technetium syringe carrier to carry the item from here, transfer it over to the infusion trolley, and then the nurses helping out with the lines. And this is basically the infusion trolley that we designed. You just can't buy these things from the usual catalogs like Capintec or the former Biodex, but often you may need to fabricate it by yourselves. And your local industry will be able to fabricate it to your specific requirements. And radionuclide therapy patients release guidelines. Well, the risk of accidental intake is very low for patients and caregivers, and should take basic hygiene measures like clean up body fluids with disposable items, and that can be flushed down the toilet, and wash your hands thoroughly with soap and water after each trip to the bathroom. Caregivers should wash their hands after each contact with the patient's body fluid, especially. And of course, the patient should receive a patient card displaying that what he or she has been treated with. So I wish to summarize and say that a comprehensive best practice guideline is needed for clinical radiation safety based on the collective operational experience of radiation safety professionals over the years while providing radionuclide therapy service at SGH. And the treatment is designed properly with well-established procedures, SOPs, to ensure safety of staff and the environment. And a primary concern is the potential of internalization of alphas and betas via inhalation, ingestion, and wounds, especially by ingestion, of course. Meticulous handling, PPE, and proper containment to prevent the contamination and exposure is needed. Staff training is uttermost, and competency assessment of the staff is crucial. Everybody needs to know how to do a decontamination, because when you least expect it, it can occur, and all staff should be empowered to do the decontamination by themselves and not look for the physicist or the RSO who may be not available. Radiation emergency and incident response mitigation. Well, as I mentioned, you need to have a SOP, and you need to rehearse and to also to assess the competency of staff who are dealing with these emergencies. The guidance obtained in this presentation will assist radiation safety professionals in the implementation of safe, practical, reproducible, and effective radionuclide therapy programs, even in small sites with limited or no experience in radionuclide therapy. I wish to thank you, and I hope you had a good conference, and you can see a bit of Vietnam soon.
Thank you very much. Thank you for giving us an excellent lecture from far away, from Singapore. Dr. Somanesan is one of our friends, and he is also an IA expert. Thank you again, and hope to see you in the future. And we might hope to have a chance to send one of our medical physicists to be trained in SGH. Thank you.
Sure. Thank you. Have a good conference. Bye.
Bye-bye.
And now we have completed the 5 presentations. And now I open for the question, answer, and discussion. Is there any question from the audience? And now we have Professor Nobet Check, and the people here can ask any question or discussion from your presentation. Firstly, I'm very happy to hear your presentation. I wonder one thing: how can we combine with the radiosynovectomy and the other therapy for the investment, example for the corticosteroids or any other blood and anything for the investment in the knee or in the joint? How can we combine? Or we
It's very easy because you are injecting just microliters. So 1-2 drops radioactivity, 1-2 drops. So the amount of what you are injecting is so small. Every joint, just the small joints of the fingers, you can inject a lot of fluid inside. Afterwards. At first, we are injecting with an own syringe, the contrast media. Then I'm changing the radionuclide, and afterwards, and this is an advantage to give also steroids to flush the syringe, to get all the radioactivity inside the joint. So this has to be trained, yes. There you have to make a fine finger work. But sometimes you have some interesting joints because of the fluid and the pressure inside. So if you're performing the puncture, the fluid come out like rain. It's like rain. So you have to reduce this pressure, and then you have enough time and enough place for your material to give it inside. You mean in one joint? I think this process will need a minute. Yeah. After synovectomy, it depends. If you have a patient with villonodular synovitis, this benign tumor of the synovia, there you have to perform the RSO 4 weeks after, because you have to irradiate the wound inside the joint just to get all this benign cells producing this tumor. And this is the right time point to reduce the possibility of recurrence. The other patients underwent resection because of thickening wall. There you have to wait the healing. So 1 or 2 months, 2 months later, then you can plan to perform this. How many we can perform per day? There's nothing described in the literature. It depends on the efficiency of this therapy. Normally, we want to see this patient just one time and never more. But a lot of people get a second and a third therapy, but then it stops. And if you are looking over years, for example, patient with knee problems, then they come every 1 or 2 or 3 years, get their RSO and walking home happy. So, and no surgery, no new joint is implemented, and it is the patient profit. Of course, This is a very, very hot topic because this is the aim of RSO to implement also in hemophiliac patient. But nowadays, the effectiveness of drug therapy is very high. So we do not see a lot of patients underwent RSO, but there are much more than we are seeing. So the colleagues has to be convinced to think that these are patients for the RSO. It's very easy. It's not expensive like